Test 1 2, test 1 2 will beginning here momentarily. Hope you can all hear us.
All right, so we're all ready to. Okay. Okay, great. It's good to know. Hi, welcome everybody. My name is Elaine Scallon. I'm the co-director of the Colorado Integrated Food Safety Center of Excellence. This center is a collaborative effort between the School of Public Health here at the University of Colorado, Colorado State University, and the Colorado Department of Public Health and Environment. We're tasked with improving surveillance and outbreak detection for foodborne diseases nationwide. And one of the ways that we hope to do that is by having these seminars at least once a semester to talk about food safety topics and topics around foodborne outbreaks. So today we're going to talk about one of the leading causes of foodborne disease in the United States, which is norovirus. Norovirus causes a lot of foodborne disease, but also can be spread person to person. We also often think about it as like the winter vomiting bug, you might hear people call it. So I think we're going to approach it in that much broader context, specifically looking at outbreaks and then different control measures. So we have our speaker, our very own epidemiologist from the Center of Excellence, who's based at the Colorado Department of Public Health and Environment, Rachel Jervis. So Rachel, as I said, is the epidemiologist working with our center at CDPHE. Previously, she worked in Colorado Springs and has a lot of experience, and I'm sure a lot of good stories to tell about investigating some of these outbreaks. So please welcome Rachel.
Thank you, Elaine. And we will jump right in and start talking about norovirus. So for those of you in the room, have you ever had the stomach flu? For those of you on the webinar, everyone is nodding knowingly at me. So Elaine already referenced my personal favorite norovirus nickname, which is winter vomiting illness. But norovirus really has a lot of names. It's also called Norwalk-like illness based on a previous name of the virus. Stomach flu, though it's a little misleading because influenza is a respiratory illness, not a gastrointestinal illness. It's also referred to as a Calici virus because that's the type of virus it is, and a bunch of other nicknames. And I think this slide hits home that you don't want it. So the symptoms of norovirus are vomiting, watery diarrhea, low-grade fever, headache, chills, abdominal cramps, nausea, malaise. You know, in general, these are described as somewhat mild symptoms in terms of gastrointestinal illness. You have no bloody diarrhea. Fortunately, rates of hospitalization are very low for norovirus, and fatalities from norovirus are incredibly low. And the individuals who do have kind of severe outcomes with norovirus tend to be people with other underlying medical conditions, particularly older folks. That being said, if you tell someone who recently had norovirus that this is considered a mild illness, they're not going to be happy to hear that. For those of you who have had it, myself included, you sort of want to die when you have this illness. It is very intense, and while it's reasonably short-lived, it's an unpleasant illness to have. So the incubation period ranges from 12 to 48 hours. When we look at kind of Colorado outbreak data and get kind of the average incubation period from those, it hovers around that 30 to 36 hour range. The duration, thankfully, is fairly short-lived, ranging from 12 to 60 hours, and we humans are the reservoir for norovirus. There's no true medical treatment for norovirus. There's no medication a person needs. However, fluid replacement therapy is also needed to ward off dehydration, particularly in the younger and older ends of this. But otherwise, it's kind of a self-limited illness that takes care of itself. And unfortunately, immunity for norovirus is quite short-lived. And that means that just because I get norovirus this winter doesn't mean I'm immune and protected against it next winter. Due to the variation and the evolution of the viruses, I don't have long-lasting immunity and unfortunately could get sick again next winter or next month. So in terms of transmission, norovirus is very highly contagious. There is an incredibly low infectious dose, so fewer than 100 particles of the virus can make an individual sick. And the virus ends up being very highly concentrated in stool and vomit when a person's ill. A person is most contagious with norovirus when they're having active symptoms, and transmission's been documented at least 2 days after recovery. So someone has been symptom-free for 2 days, and they've still gotten other people sick. Meanwhile, we know the virus can be shed a lot longer than that, potentially 4 weeks, maybe even longer, because we can detect that through laboratory testing. Though certainly when a person is symptomatic, that's the highest risk of them sharing a norovirus illness. So noro is spread through the fecal-oral route, and that can happen through food, water, person-to-person, or environmental contamination. So, for example, food, if you have a food handler who didn't wash their hands particularly well and then plated the garnish on everyone's plate for a wedding reception with their bare hands, that's a way food could become contaminated with norovirus and share it with a lot of people. Any water that's contaminated with feces could contain norovirus. That definitely happens as well. And then person-to-person spread is really a huge player in norovirus. If you end up with norovirus at home, there's a really good chance your roommates, your family, whoever's around you could also get norovirus just because it's so highly contagious. And then finally on that list are the fomites and environmental contamination. Anyone seen anything in the news about a certain well-publicized noro outbreak recently? For those of you on the webinar, someone said Princess Cruise, and yes, that's exactly the one I was looking for. So on cruise ships, you have there are a lot of ways norovirus could be spread on a cruise ship. It could have been through food or water. It certainly could be person to person, but this is an area where we have really well-documented environmental or fomite transmission. So on this particular cruise ship outbreak, the last I read was a few days ago. The ship's currently docked in California for some deep cleaning, and they know of at least 172 people who were sick on this cruise of about 4,000. So hopefully they are doing their due diligence with their cleaning and disinfection, because in previous outbreaks, we've known that even though the cruise ship was cleaned and the entire staff, or crew, I guess, and passengers have fully turned over and it's all new people, the outbreaks continue. So apparently something was not cleaned and people were still coming in contact with that, whether that be an elevator button, a door handle, a sink handle, etc. Finally, norovirus can also be spread through the air. Now, it's not an airborne illness the way measles or chickenpox is. However, it's been documented that if an individual vomits, the virus can be aerosolized. And there was a dinner party outbreak that's been published that an individual had a public display of vomiting, as we call it, at the dinner party. And people around that individual became sick following that exposure. So I think the cruise ship example highlights that norovirus is incredibly persistent in the environment. It's been recovered after 3 to 4 weeks at room temperature. At 4 degrees Celsius, it's been detected for up to 60 days. Now, I do need to kind of provide a caveat for that. The way norovirus is tested for is through polymerase chain reaction, or PCR, and so that's looking for the DNA. So these numbers are telling us that after 3 or 4 weeks or 60 days at the lower temperature, norovirus DNA is detected on surfaces. However, we don't know if that's healthy, viable virus that could then infect another person. So the virus is detectable, but it's unclear how, risky the presence of that virus would be. Noro can be inactivated by heat, 70 degrees Celsius for 5 minutes, or boiling for 1 minute, for example, with water or instruments that could be boiled. And then a study showed that after fingers become contaminated with norovirus, those fingers can transfer norovirus to up to 7 surfaces. So if I'm sick, I don't wash my hands well after using the bathroom, potentially the next 7 surfaces I touch, including perhaps your food, could be contaminated with norovirus. So in a large hotel outbreak, they actually went through and did environmental testing during this outbreak to see where the norovirus was persisting. And so they tested these surfaces and found that on carpets, regardless of whether or not there was a known instance of someone vomiting near this carpet, there was norovirus detected on 62 to 75% of carpets in this hotel. Around the toilets, it was 73%. Toilet handles and sinks were 37%. Phones and door handles were 24%. And soft furnishings, so couches, upholstery, that sort of thing, were 20%. So later in the presentation, we'll talk about disinfecting and sanitizing around norovirus, but this just kind of highlights why that's so important. And I would recommend not staying at this hotel next time. I think this happened in the UK. All right, so now we've talked about how incredibly persistent norovirus is in the environment, how it's incredibly contagious, and how you unfortunately don't really get immunity to this. And this together is just the perfect storm for a norovirus outbreak. This is why norovirus outbreaks are so common, and particularly when people are in close settings, such as on a cruise ship, in a nursing home, that sort of thing. So before I go on, does anyone either in the room or on the webinar have any questions? No? All right. So let's talk about norovirus outbreaks. So norovirus outbreaks could either be common source or person to person. So common source means that everyone was exposed at the same time. Oftentimes this would be a contaminated food product. And so you have a huge spike of illnesses, and then it gradually comes off, and then you have additional waves of illness. Because even with a point source outbreak or common source outbreak, person-to-person transmission still often occurs after that. Other outbreaks are entirely person-to-person, so you have an individual who's sick, they come in contact with others and expose them, and it just kind of keeps moving from there. And these tend to have a more gradual kind of epi-curve. The settings that you see these happening in include long-term care facilities, that's a really large one, restaurants or catered events, schools, hospitals, child care centers, camps, cruise ships, swimming pools. We've had norovirus outbreaks in swimming pools. So it's kind of the who's who and the where's where of outbreaks. Norovirus really kind of can cause an outbreak in most places. So this slide is looking at specifically at foodborne illness outbreaks between 2009 to 2012. And so just of outbreaks associated with contaminated food, norovirus is 48% of those. So the next kind of largest group are the bacterial pathogens, and those are 46%. But within that 46%, it's all sorts of bacteria. It's everything from Salmonella, E. coli, Campylobacter, and so really, it shows what a big player norovirus is. So then looking at the settings of norovirus outbreaks that have been reported through the National Outbreak Reporting System, or NORS, that's how CDC collects and manages data on outbreaks. So this is looking at 2009 to 2012. And the largest percentage, unsurprisingly, are healthcare facilities. That includes nursing homes, long-term care facilities, but also other facilities, including hospitals. And so those are the largest percent. followed by restaurant or banquet facilities, schools or daycares, and then private residences. And this private residences number, it's only 1.9% of outbreaks, but I will tell you that that is drastically underreported. So we have systems in place for long-term care facilities to contact us when they have an outbreak of something that may or may not be norovirus. We have ways to detect restaurant outbreaks. You know, smaller kind of household outbreaks are not reported to us as much. They tend to be smaller outbreaks with fewer numbers of ill people, but there's a lot of them happening. So this is definitely, I would say, very underreported. So norovirus also has a seasonality and a cyclical nature. Certainly norovirus can happen year-round, and it does happen year-round, including summer camps, but it is most common in the winter, hence winter vomiting illness. And they've found that in years that there's a new strain of norovirus circulating, you can end up with as many as 50% more norovirus illnesses. And so kind of the recent years that there's been a new strain going around were winter 2002, 2003, 2006, 2007, and then most recently, 2012, 2013. And that got a fair amount of media publicity outside of the public health world. It was the Sydney strain of norovirus, that's how it was referred to, and it really was you know, a new strain that there was even less immunity to, and so you were seeing a lot more illnesses. And you'll notice those, just with those 3 sets of years that we had new strains and increases, those are very cyclical, coming every, let's say, 4 years or so. Okay, so I want to show you 2 things on this slide. This is the number of reported norovirus outbreaks by primary transmission mode and month of onset, again from national data from NORS. And you'll notice this darker green color at the bottom are the foodborne outbreaks, and those are a fairly small percentage when you look at all outbreaks. Then I want you to look at the seasonality and tell me the months that we're seeing the most norovirus. All right, so for those of you on the webinar, we got January as the answer, which I would agree with. Really, the absolute bulk of the area under this curve are happening, let's see, from December through March, maybe into April. So we really are seeing that seasonal trend quite strongly. So to look at this specifically in Colorado, I pulled data from 2009 to 2013 for you. And in that 5-year period, there were 902 norovirus outbreaks reported. And you'll notice that kind of the highest numbers in this time frame are 2012, 2013, which lines up with that new Sydney strain of norovirus. So despite norovirus's seasonality, for kind of public health surveillance and reporting purposes, we really look at outbreaks on an annual basis. For some diseases such as influenza, you look at it more in a seasonal way, but just the way that we capture and share all of our outbreak data, we primarily look at it on an annual basis, so that one kind of really rough winter is kind of spread over 2 different years in our outbreak reporting. So on this slide, we're looking at the rate of foodborne versus non-foodborne outbreaks. And I apologize, this color might be a little hard to see. But the bottom blue color are the foodborne outbreaks. And the remainder are person-to-person or other transmission. And just like the national data showed, in Colorado, only about 7% of our norovirus outbreaks are a food source. So hopefully the previous slides have kind of conveyed why norovirus is a public health menace and why it is a source of many outbreaks and illnesses, and why we really do need to focus on control measures to both prevent outbreaks and minimize outbreaks once they are detected. But in case that hasn't, I'm going to give you one more number, and that is 29,210. And that is the number of individuals that became sick in those 902 outbreaks. That's for an average of 32 ill persons per outbreak. And this doesn't include any of those little household outbreaks that never got reported, any sporadic cases of norovirus, which are not reported. And yet, that's still a very large number of people who got sick from norovirus. So any other questions before we jump into control measures? Yes, Randy. Okay.
So Marisa is asking, isn't it an RNA virus?
It is an RNA virus, so you're right. Technically, it should be RT-PCR, so reverse transcriptase. PCR, polymerase chain reaction testing. Yep, it is an RNA virus.
And Adam Kramer is asking, while there isn't long-term immunity, isn't there some genetic susceptibility depending upon blood type?
Okay, so for those of you who may not have heard the question was, while there isn't long-term immunity to norovirus, is there some kind of correlation between blood type and susceptibility to norovirus? And to be honest with you, I am not sure, but I would love to learn more about that. So if possible, if there's a link to an article or study about that, I would love to take a look at that. That's not something I know about.
And Jacqueline is asking, can chlorine, like in swimming pools, kill the virus?
Okay, so the next question from the webinar was whether chlorine from swimming pools can kill the virus. And that all depends on the concentration of chlorine. And we will talk about that when we get to cleaning. Do we have any pool operators, waterborne gurus, either on the webinar or in the room? Because to answer that question, I would need to know what the parts per million of sodium hypochlorite are in a properly chlorinated pool. So we'll see if we can research that and get back to you on that question by the end.
Would Linnea know? She's typing.
Oh, Linnea may know.
Okay. Nabi asks, why aren't the cases more evenly spread throughout the year if humans are reservoirs?
Okay, so this question's about seasonality and why cases aren't spread out more throughout the year. I think part of it is kind of communal gatherings and putting people in closer settings. We tend to be indoors more in the colder months, particularly here in Colorado. And also that just seems to be the natural pattern of the virus. While we see it throughout the entire year, it's most common in the winter. So even, long-term care facilities, this is a group of people who are always in close contact throughout the year, and nonetheless, we see very few noro outbreaks through the summer months, and they start ramping up right around this time.
Linnea says that it is 0.25 parts per million to 5.
Point.
0.25 to 5 parts per million.
Okay. We will get back to that number because that will answer our question very shortly.
And Adam also says swimming pools typically have a free chlorine residual of 1 to 3 parts per million.
Okay. So unfortunately, no, that's not going to cut it for norovirus. Okay. Any other questions? Questions in the room? All right. Okay, so let's jump into control measures to norovirus. So we'll start out by talking about the public health response. Our communicable disease regulations in Colorado give both state and local public health agencies the regulatory authority to investigate any outbreak, regardless of setting or believed etiology. And in Colorado, the vast majority of these outbreak investigations are happening at the local public health agency. They're the ones who are doing the, bread and butter outbreak work. And we at the state health department only get involved if there's kind of an unusual situation and they'd like consultation, or if it's a larger outbreak that's crossing county lines and there's a need for more coordination. But primarily, these are our local public health agencies who are working a large number of these outbreaks every year. And we very much rely on our environmental health colleagues for their expertise. So both in evaluating kitchen practices, and this could be at a restaurant or a healthcare facility, and also implementing the disinfection procedures and other control measures. So in terms of, whenever we teach about outbreaks or case investigation, the first thing we always say is to verify your diagnosis. Find out what the pathogen is, and so that you can tailor your control measures and activities that way. So as I said before, norovirus can be detected through reverse transcriptase polymerase chain reaction, so RT-PCR, and this is widely available at commercial labs, and it also is done at our state health department on a fee-for-service basis. In some outbreak situations, the state covers the cost, but not in all, and so it's kind of depends on the situation. And testing is very rarely done for single cases. And honestly, partially that's because, it's a self-limited illness and a lot of people don't present to a healthcare provider for testing in kind of the private healthcare world. And then from a public health perspective, knowing exactly what made one person sick isn't as meaningful to us. We're really focused on what's causing a larger burden of illness. And in terms of kind of patient care, there's no specific treatment for norovirus besides maintaining hydration, and so there isn't a clinical need to know. So during an outbreak investigation, we typically recommend testing 2 to 6 specimens, so you have a range of specimens and hopefully can get some positives from that. So norovirus can be detected in food and water. However, testing is very limited. It's still fairly challenging and expensive to do. So it's not routinely available, but it is possible during an outbreak situation, and that's something that, you know, the individuals investigating the outbreak would kind of consult with the state public health lab and determine what's feasible in that situation. But one of the most important things I want to stress is that during a norovirus or a possible norovirus investigation, you would never want to wait for any confirmatory testing before moving forward. This is such a contagious virus where outbreaks can very quickly kind of run rampant that you would never say, oh, we're expecting to get test results in the next day or two, we'll just hold off and not do anything. You would start implementing control measures right away in the hopes that, you know, if this is norovirus, you can nip it in the bud. And if you later find out, hey, that wasn't norovirus, it was salmonella, great, you can ease up on some of your control measures, but you'd kind of rather start with the more stringent control measures. So I like to joke that if I had $1 for every time I told people like how important hand washing is in public health, I could retire a lot sooner. Unfortunately, no one's paying me each time I say this. But hand washing is very important for norovirus because of how easily it can be transmitted on hands and to surfaces. And so anytime you have a norovirus outbreak, regardless of the setting, you're going to recommend increased hand washing. So whether that's among residents of a long-term care facility and their staff, food handlers, children or students at a childcare or a school, and you really want to recommend it for everyone. Obviously, it's important for the ill people to wash their hands so they can't spread it, but also for the well people who are walking around and touching things, you want them to be washing their hands more frequently to reduce the chance that, you know, their contaminated hands make them sick. So the next control measures are about food service. So in this, it's important to note that this is anywhere that there's a kitchen. So this is, often we think about this in restaurants, but this is also in long-term care facilities, school cafeterias. Some childcares have kitchens on site and prepare food for the children. So anytime you have food service happening, it's really important to prevent food handlers from working while they're ill with diarrhea and vomiting. And this is where sick leave policies are really important. So encouraging employees to identify when they're sick and stay home is really key. And so whenever that's kind of part of the culture at a facility, it increases the likelihood that it's going to happen. And also encourage workers to report on-the-job illness to managers because there's kind of urgent things that can be done. You know, you don't want an employee sticking it out the rest of their shift and then calling in sick for the next shift because it's possible that in their time at work there, they could have contaminated something and there's food that should be thrown away or special cleaning that should be done. Now, excluding ill workers happens not only while they're ill, but afterwards. And for a single ill worker, the recommendation is that they be excluded for 24 or more hours until after their symptoms resolve. During an outbreak or a situation you have more than one ill worker, we want to bump that up to between 48 and 72 hours after the illness resolves. And that's because that's when we really see, you know, the level of virus in the stool and the chances of someone infecting others really go down. Facilities also should increase cleaning and disinfecting and suspend self-service food. So for example, if I'm, you know, a kitchen manager at a long-term care facility and we have a salad bar, if there's a norovirus outbreak going on in my situation, that's when it's time to close the salad bar and serve plated salads. So that if you have someone who may have contaminated hands, they're not handling utensils on the salad bar. Okay, so moving on to healthcare facilities, exclusion of ill workers is also really important here, and the recommendation is to exclude them for 48 hours after their symptom resolves. And again, this is both the healthcare providers and the food handlers. I definitely know of a number of outbreak investigations where we epidemiologists are really gung-ho to find out, you know, what staff members are sick, what what direct patient care are they providing? When did they get sick? Were they getting sick before, after residence? And we sometimes forget about food handlers, and those are one of the early people you want to ask about. Gee, have any food handlers at your facility become sick? You're not sure? May I please talk to your kitchen manager? And really getting to the bottom of that, because that's, again, a very important area for exclusion. Also, increasing facility cleaning and disinfecting with appropriate agents just across the board throughout the facility is important. And then facilities should consider a few things, and one of those is restricting new admissions. So if I have a facility that's experiencing a norovirus outbreak and we have new patients, new residents who want to come there, what we don't want to do is bring a healthy, susceptible person into my norovirus outbreak because there's a decent chance they're going to get sick. So we'd really rather wait until that happens, or until the outbreak has resolved to admit new residents. Now, sometimes a lot of these facilities are kind of like broken off into units or pods, and in that case, if the outbreak's really concentrated to one area, it may be okay to admit new residents to other parts of the facility. The other thing that facilities consider and often do are posting signs to warn visitors that there's an outbreak, or even restricting visitors. And this is kind of a hard decision to make because visitors provide a lot of, social interaction for the residents, and you don't want your residents feeling particularly, isolated because they can't have visitors. But what we don't want to do is expose these visitors to norovirus and then have them bring that back to their households, the restaurant where they work, the child care facility where they work. And so that's, it's usually a decision made on a case-by-case basis, but it's often a decision that needs to be made. So specifically for residents of a long-term care facility, they need to be on contact precautions for at least 48 hours after their last symptoms, just to reduce that risk of transmission to healthcare workers and others. If possible, if they can be in single occupancy rooms, that reduces transmission, though that's not always an option depending on the facility. And we also want to restrict movement for ill persons. So you don't want, someone who's ill coming down to the dining hall to join others to eat and handle things. Likewise, you don't want ill persons attending a group activity. So, if kind of everyone in the facility, or, there's illness dispersed throughout the facility, it's probably time to cancel some group activities, different classes or other things that may be available. If it's a smaller group of residents who are ill, it's possible to continue those activities and just exclude those ill persons until they're done with their 48 hours of contact precautions. And because this has such a huge impact on the residents, their movements being restricted, they may not be allowed to have visitors. It's important for staff and family members to kind of do other things they can to decrease feelings of isolation among the ill residents. So whether that's encouraging families to call more often, or arranging other special things for the ill residents, it's nice because they are otherwise somewhat isolated during this period. So in child care facilities, exclusion is very important as well, excluding ill children and staff for at least 48 hours after their last symptom resolved. Oftentimes letters are sent home, both to notify families that they're experiencing gastrointestinal illness at the facility and remind families of the exclusion policies. These facilities should have policies in place of when it is acceptable and not acceptable to send your child to child care with certain symptoms. So this is a kind of a good time for facilities to remind parents of what their policy is. And then again, increasing hand washing among staff and children. We know children have very, very different ideas of personal contact boundaries, and oftentimes lower quality hand washing. But as much as we can do to wash hands is important. And so this is another situation where public displays of vomiting come up because sick children don't always make it to the bathroom to become ill. And so if there is a public display of vomiting, it's important to clear the other kids out of the room to get them away from any aerosolized norovirus, and also to make sure surfaces are clean before kids come in and touch them. And again, increased cleaning. So, okay, we're about to get into cleaning, but before we do that, does anyone have any questions or comments about other control measures? Randy's nodding, so I think we definitely have some from the computer.
Jacqueline asked, what is the fee for the test of
Ooh, what is the fee for norovirus testing at CDPHE? I do not recall. I want to, no, I'd be making that up. No, I'm not sure. I can get back to you on that if you provide me with an email address. I'd be happy to get back to you. I don't recall what it is anymore, and I don't want to give you an outdated number. Any other questions? Okay. So yeah, just Jacqueline, if you can, either afterwards you can email me or Randy, whose contact information is on the flyer. I can get that information to you. Okay, so I have stressed how important cleaning and disinfection is, probably every slide for the past 10 to 15 minutes. So let's talk about how that's done. So first I'm going to tell you about the products that do not do the job against norovirus. And these are quaternary ammonia compounds, detergents, and ethanols. These will not deactivate norovirus. Other things that are effective are chlorine, phenolics at 2 to 4 times the manufacturer's recommended concentration, iodine, glutaraldehyde, heat, again at least 140 degrees Fahrenheit, hydrogen peroxide, and ozone. However, the caveat to all of this is that is only at the proper concentration and for the proper contact time. And we tend to see chlorine used the most. It's not because chlorine is any more effective than the other products, but it's very readily available. So if you, routinely are cleaning with something else in your facility and think you have a norovirus outbreak, it's pretty easy to go pick up bleach, mix it, and use it there. And it's definitely less expensive than a lot of the commercially available products. So because bleach is so commonly used, we want to talk about how to mix it to be effective against norovirus. And so the first thing I need to tell you is that this is a change. And any of my local public health partners on the webinar are looking at this and shaking their heads because this is not what is currently in the CDPHE guidelines. And that is because commercially available bleach has become more concentrated. So a few years ago when you bought bleach, it was anywhere from 5.25 to 6.25% sodium hypochlorite. And now almost all the bleach you can get, and I have done a fair amount of bleach looking at Target, King Soopers, and a couple other places. Almost all of the bleach is now an 8.25% sodium hypochlorite, so it's more concentrated. Now, in some ways you'd think, gee, using too much bleach to kill norovirus doesn't sound like that much of a problem because you'll take care of it. But the flip side of that is that bleach can be corrosive. If you've ever walked into a room after bleach has been used to clean, it is not a pleasant smell. So kind of getting it to the correct concentration for both to, kind of the lowest concentration that's effective to kill norovirus is really important because it's going to make it a lot easier to use and increase people's kind of compliance with using it. So at this new concentration, our goal is to reach 5,000 parts per million sodium hypochlorite. That is what we know kills norovirus in a 1-minute contact time. You can use much lower concentrations, however, you need a 10-minute contact time. And I don't know the last time I cleaned something and it stayed wet for 10 minutes. It's really hard, particularly here in our dry climate. So with this 1-minute contact time, the surface you're cleaning needs to stay wet for a full minute. And to make this 5,000 parts per million sodium hypochlorite solution, you use 1 cup of bleach and 1 gallon of water. A gallon is also 16 cups, so that's how you prefer to look at it. And that is the solution you need to make to have the correct concentration for norovirus. So we have a School of Public Health student who's actually working on a practicum with me, and she's been putting together a new guidance document regarding bleach. And we're hoping that'll be ready in the next month or so. And then after that comes out, the State Health Department has a lot of guidance documents around norovirus, so we will be updating each of those to include this new recommendation of cleaning. It's also important to note that for food contact surfaces or toys that a child is going to put in their mouth at childcare, after this disinfection step, they need to be rinsed with clean water and routinely sanitized because this concentration of sodium hypochlorite is not approved to be eating off of. I wouldn't want that on my plate and then food on it, or to eat food off a counter, for example. So going back to the previous question about swimming pools, even at the longer contact time of 10 minutes, I believe it's around 1,000 parts per million sodium hypochlorite. So that 0.25 to 5 parts per million that is in swimming pools would not be effective to kill norovirus. However, after there's a known accident in a pool, the recommendation is to shock it with a higher level of chlorine. And so that, I don't know exactly what the shocking recommendations are. Linnea could probably tell us if people are curious. But that level of sodium hypochlorite to shock it is effective to kill norovirus. Okay, so I've told you about disinfection, and now I need to tell you about cleaning, which happens before disinfection. So one study showed that, kind of demonstrated just how much disinfection only works well on already clean surfaces. So they took surfaces and contaminated them with norovirus-laden feces, and then they applied this appropriate concentration of 5,000 parts per million sodium hypochlorite for 1 minute, the correct contact time, and unfortunately found that norovirus was still present on 28% of surfaces. However, when they cleaned those surfaces with a detergent first and then applied the same correct concentration of bleach for the same contact time of 1 minute, norovirus was not left on any of the surfaces. So again, bleach and all of these other approved products are very effective against norovirus when applied appropriately to a clean surface. Okay, so I want to provide some resources for you. On our State Health Department website, we have a lot of outbreak resources, particularly outbreaks in specific settings. So we have specific long-term care facility norovirus guidelines, summer camp, childcare, et cetera. The CDC norovirus website also has a lot of good information. And then this third link, this is the list of disinfectants that are effective against norovirus as tested by the EPA. So all those kind of other compounds I listed under bleach, these are products that typically contain those. And it's important because not all kind of hospital-grade disinfectants are effective against norovirus. So it's important for a facility to kind of look at this list and make sure they're using an appropriate product. And I have this highlighted because this was actually updated within the past few weeks. We've been working on with a version from 2009 since 2009, and we now have a 2014 version, which is a bit more robust. Certainly products are being approved against norovirus by EPA somewhat regularly, and so now the guidance document's updated to match that. So that's very helpful. So now I'm happy to take any remaining questions. Yes, we have one in the room. So for those of you on the web, the question was if the kind of cleaning, disinfecting wipes are useless. I don't want to say useless. How about not effective against norovirus? For starters, look at the ingredients in those. I probably talk and think about bleach way more than your average person, and yet not too long ago, I looked at the one in my cabinet, and it's made by, Clorox, and it contains 0 bleach. So while it's effective against a number of other things, it would not be effective against norovirus. So in terms of kind of cleaners to have around your house, I think chlorine bleach is the most common and easy to use. I think these other products that are effective against norovirus are readily available as kind of professional disinfectants and harder to find kind of at your grocery store. Okay, so the question is about a fabric surface. And one moment, please. I am going to turn to my handy-dandy vomit and fecal accident cleanup guide, which is at the end of our long-term care facility noro guidelines, because this is a situation where steam cleaning can be used because you can get it up to that temperature. Let me see. So linens, so sheets, towels, blankets, those can be washed with bleach, and that's very effective. Soiled carpets and upholstery are very difficult to fully disinfect and may not be feasible to use the bleach solution if damage to the material will occur. So for example, I'm probably not going to bleach my couch. I don't think it would stay the same color. So they recommend either using other disinfectants that are effective against norovirus from this EPA list, because not all of them will damage, or steam cleaning. And if your steam cleaner gets to that 140-degree temperature, that's effective. Oh, excellent.
So diarrhea in the pool, it must be closed for 24 hours, and chlorine must be at 20 parts per million for at least 12.75 hours. And for vomiting, remove the vomit from the pool and ensure pool chlorine when pH is within its limits, closed for 1 hour. So actually, pH of 7.2 to 7.8 and chlorine at the typical 0.35 to 5 parts per million. Although that sounds like not for killing norovirus, just for accidents.
So did folks on the webinar hear? Were you guys able to hear that?
No, Marisa says
Okay. Here, I'm going to walk back with the mic so you can repeat that.
no. Well, they can read it.
Oh, they can read. Okay, so basically, that was the information that's in your little chat box about what happens in terms of closing pools after either fecal or vomit accidents, and kind of how long the pool stays closed in the hyperchlorination.
We do have some questions also. Nabi asked, how many circulating strains of norovirus are typically circulating in the U.S. and in Colorado specifically?
That's an excellent question that I'm not sure if I know the answer to. So those of you who couldn't hear the question, it was about the number of strains of norovirus commonly circulating. So there's 4 major groups, and among those there's a number of strains, and I am genuinely not sure how many are circulating. I think, we only do kind of specific typing when we know there's a new strain out there. So during the winter of 2012, 2013, we were doing additional testing to identify the strain to see if we had any of that newer Sydney strain. My guess is that there's a number of strains circulating, and that's why this immunity issue is such a challenge.
So does that also answer the question, do we currently use genome sequencing for surveillance of norovirus? That was his follow-up.
Okay, so the follow-up question is about genome sequencing for norovirus. This is done very rarely. I'm trying to think. The last time I know about additional sequencing being done on norovirus was an outbreak about a year ago, and it was at a hotel, and they had 2 outbreaks. Well, we were trying to determine if they had 1 outbreak or 2. They had an outbreak among staff and guests, then there were no illnesses, and then there was another bout of ill persons. And what we were trying to determine was, are these 2 separate outbreaks? Are these the same outbreak? And it just kind of quieted down in the middle, or fewer people reported it. I mean, at a hotel, if you become ill in your room, are you necessarily going to call the front desk to report your gastrointestinal symptoms? Probably not. And so we did do additional testing on specimens from those 2 outbreaks, and they were the same strain of norovirus. They were the same, so.
Marisa, well, Nabi's response is you can contact him if you're interested in doing genomic surveillance.
Cool.
Marisa has a couple questions. Do you recommend wearing a mask when cleaning contaminated areas?
Yeah, that's a really good point. So a lot of the times, the staff who become ill at a long-term care facility during a norovirus outbreak are the cleaning staff who have cleaned up soiled items. And so, masks are not required because at that point we're not concerned about aerosolization. However, they're often used and recommended just because they prevent people from having contact with their face accidentally. I can't accidentally itch my cheek if I'm wearing a mask, or I'll think twice about doing it. So oftentimes masks are used to clean, definitely gloves. Sometimes people even wear gowns, so it's easy to just take that off and toss it.
What radius do you recommend for cleaning vomiting?
That's an excellent question. So the question is the radius to clean around a public act of vomiting, public display of vomiting. Let's see. I think we typically do the entire room. However, in a very large room, that could be problematic. Okay. It would be in the vicinity, and if it's a larger room, it's within a 20-foot radius, 25-foot radius, pardon me.
Just keep them coming.
Okay, we also have a couple.
Oh, okay.
So why don't I have 2 questions in the room, and then we'll do 1 more from the web. Does that sound okay? Because there is someone else in this room after us. So, you had a question?
Yeah, I've been on cruises before.
Uh-huh.
And they always have you, when you're going into the buffet, they
Mhm.
require you to use alcohol stuff.
Mhm.
And I've been there when I think suspected norovirus tables are just swamped with fluid. But does this give a false sense of security too? I mean, that's rough.
So for those of you on the webinar, the question with a demonstrative bottle of hand sanitizer are whether alcohol-based hand sanitizers are potentially giving people a false sense of security about protection against norovirus, such as on cruises or other places. So the recommendation for everything is that if your hands are visibly soiled, to wash them with soap and water, period. And that alcohol-based hand sanitizers are really for a time that hand washing is not readily accessible or available. So norovirus, norovirus is hard to study in the lab. They use a feline calicivirus as a proxy, and these alcohol-based hand sanitizers are not particularly effective. They're better than nothing, but they're not nearly as good as hand washing. So ideally, having a hand washing station for everyone to wash their hands with soap and water before they go in would be better. That being said, everyone thinks I'm crazy because I'm an epidemiologist who's planning on going on a cruise this summer, but you will never see a cruise patron wash their hands as often as I do. What was the next question in the room?
I was wondering if you know about how fast the virus mutates.
So the question is about the rate that norovirus, the viruses mutate and evolve. I don't have a specific rate or number. I'm not sure if our genomics expert in the webinar may. And I don't know. I know it's kind of constantly happening, but I don't have an exact rate or pace for you. And can we take one more question from the webinar? And I'll walk over to the people on the.
Sure. So I think, Marisa, how about hand towels versus air dryer?
Oh, hand towels versus air dryer. So would this be like cloth towels or the paper towels? Paper. Okay. I am not sure if I've seen a study on this, though I believe in the food regs in kitchens it should be with paper towels. And my personal feeling is anytime I'm at one of a place that has the blow dryer but not the paper towels, how am I supposed to get myself out of the bathroom without touching the doorknob? Because I'm that person who won't touch the doorknob. And I believe that's one of the reasons paper towels are recommended.
Paper towels are often recommended because people don't dry them under the hand dryers for long enough. So if they're properly used, they can be effective, but the hand dryers, like whoever stands there until everything is like bone dry and there's somebody standing behind you. So it's the implementation of
Okay.
the big what about those Dyson things that scare me? It just goes off. So
So for those of you on the webinar, our final two comments were that one of the reasons that paper towels are recommended over the hand dryers are the kind of human use and implementation is that people don't usually keep their hands under the dryer long enough to get them fully dry. And then we discussed the scary Dyson things that spray water everywhere, and I will agree that spraying the water makes me a little nervous as well. So I'd like to thank all of you in the room and on the webinar for joining us today. If anyone feels a burning desire to ever watch this again, it is going to be recorded on the website. I'm guessing you're the audience who doesn't need to know that because you were here today. And certainly for those of you who posed some questions I didn't know the answer to, I will look into those and get back to you. Thank you. Can I? Sure. How do I?
I will.
Oh, okay.
So those new hand dryers, you've seen those ones that sound like a jet engine going
I
up.
do.
You slide